Some centers will have a major operative and they will also give you a minor operative. So all depends upon the center, and every operative may have a 5-mark surgical anatomy. So it is up to the center or up to the examiner or up to the convener how does they want to split the marks. But the total number of marks in an operative class is 20. Always remember that. Now before we start writing, if you have not attended the last class, this is the list of the operations that are basic requisite. We will have some minor additions to this list. Example, operations of the stomach. Example being, say, operations of pseudocyst of pancreas. These will be the minor additions. Colostomies and ileostomies will also be added to the list. But if you have taken down the list, it is nice. If you have not taken down the list, we will have just 2 minutes and then we'll start on with the minor operatives first and then we do the major operatives. So take a minute and noting this down. If you have not noted this down.
আজকে সন্ধ্যের ক্লাসে মানে পার্ট 1 পড়াবেন না পার্ট 2 মানে অপারেটিভসই পড়াবেন না আগের দিন যেখানে থিওরিটা
I think it is part 2.
Acha.
We will be talking about the practicals only.
Okay, sir. Okay, sir.
Practical what topic? Let us see. Please take 1 minute in completing the list. If you have not completed the list, or if you have completed the list, please inform me and then I will start them.
স্যার থাইরয়েডের উপরে কোলেসিস্টেক্টমি লেখা আছে
Cholecystectomy, open and lap.
Done, sir.
Okay, complete. Chalo. So give me a minute to start. Let everyone complete writing the list. Have you completed writing, sir?
Yes, sir.
Thank you. Let us start now. So, whenever we talk about an operative, remember operative at an MBBS will carry a maximum of 20 marks. We have done the 80 major marks of your long case and short cases. That has been the major bulk of your discussion. Now, in the operative chat, the marks can be split in various ways. It can be a major operative. It can be a minor operative. It can be a surgical anatomy. But whatever it is, the examiner will like to have 15 and 5 and 5. So either this or maybe 2.5, whatever he likes or she likes will be the main topic of discussion. But overall, cumulatively, this is 20 marks in totality. Next one, what is the format in which we discuss any operative? As I have said, this is an undergraduate class. This is not a postgraduate class. We do not expect you to mention each and every technical steps of the operation. So please remember this one. So the basic points that the examiner is wanting to discuss will be indications, and contraindications of the operation, or when to do and when not to do the operations. Pre-operative preparation. Okay. Number 3 is, so indications and contraindications are number 1. Number 2 is pre-operative preparations. Number 3 will be anesthesia. Number 4 will be incision. Number 5 is major steps or salient steps of the operation. Number 6 is drains and closure. Number 8 is post-operative direction, and number 7th is post-operative direction. Number 8 is post-operative complications. So these are the 8 points that any operative procedure will have. If you have completed writing, please tell that to me. Then we'll proceed.
Done, sir.
Done? Wow, good. Just allow me a second for everyone to complete. Just allow me a minute. 8 points, and then we start with the first one. Hello?
Yes, sir.
Hello?
Yes, sir.
Right. Okay. Am I audible now? Right.
Yes, sir.
So let us complete the list. Let us start with the first one, the lump excision. And as I have said, this is an MBBS undergraduate class. Please do not expect this to be a postgraduate step-by-step discussion on an atlas in surgery. So you are not required to know the technical details. Now the first operative, so we'll start with the minors first and then we'll go to the major. When you have the minors to start with, the number 1 is a lump excision. And when you have the lump excision, the points to remember in the lump excision means we are talking about a lipoma, I am talking about a sebaceous cyst, I am talking about a mole or a nevus excision. So anything that means related to the skin and the subcutaneous tissues will be discussed. Now, the first one, as I have said, come to the format, the indication. So the indication of these operations are cosmetic, number 1, pain, number 3, suspected malignancy. Okay. What are the contraindications? Now they do not have any contraindications except that, remember, coagulopathy is a common contraindication. Then coagulopathy is the common contraindication. Patient's refusal for the operation. These are again common things that will be seen across the day. You can use this word everywhere. If you have completed writing, please tell me.
Done, sir.
Answer.
Then after this is the step number 1. What is the step number 2?
Preoperative.
Preoperative preparation. Usually all the minor pre-ops, all the minors will at least require you to have a blood for hemoglobin, TLC, DLC, DT, CT. Some people do also the INR and the platelet count. Diabetics, if they are known diabetics, it is good to have at least a fasting sugar and a urea creatinine. If they are a known diabetic, this is the bare minimum investigations that you are required to do for a minor operative. For major operatives, we will have the longer list, not like this. So please tell me if you have completed writing.
Done,
Okay.
Done, sir.
What is the third point?
Anesthesia.
Anesthesia. Good one. This is to be done under local anesthesia. This is to be done under local anesthesia. The drug of choice is lidocaine, which is used as an infiltration / injection anesthesia in this operation. The dose of lidocaine is lidocaine or lignocaine, what is it called as, without adrenaline, is used in the dose of 3 milligram per kg per day is the maximum allowed dose. Please remember that. The lidocaine or lignocaine with adrenaline increases the dose to maximum 5 milligram per kg per day max. It can be little more, but I will not be telling you that one. We make it 5 to 7, but you keep it at 5, 3 and 5. This is something even asked in your MCQ exams. What is to be remembered is that before the injection or before infiltration of the drug, always check for allergy to the drug. Why? The preservative of lidocaine or lignocaine is called as methyl paraben. All lignocaine injections have this as a preservative, or technically say, for example, a parallel drug. So this is the agent that is responsible for the allergy. So always take allergy to the drug. And always number 2, before infiltration, confirm that the needle is not in a vein. Very simple. That means pull, then push. What do you mean by this pull and push story? If this is a syringe, this is the needle is in the tissue, always pull. If blood comes in the syringe, what do you understand then? That you are in a vein. Then do not push the drug, please. If blood does not come in, that means you are not in a vein. Then push the drug. Can you tell me why are you taking this precaution with lignocaine?
IV can cause cardiac arrhythmia.
Very good. IV can cause a bradyarrhythmia. First, this is only single line that we want to know. So lignocaine or lidocaine has a very bad effect on the heart, and people can die. If you have read Agatha Christie's stories, then remember that one. So it is probably the ABC murders, I forget that. But still, so IV bradyarrhythmias are this. So this is all about the first one, anesthesia.
Pull pushta please আর একবার বলবেন
Pull push means that whenever you inject a lignocaine, say for example, this is the drug, this may be a vein, okay? The problem is that if you inject it in a vein, the blood is directly going to the heart. The patient will have a cardiac arrest. So to avoid that, you pull when blood comes in the syringe, that means you are in a vein. Do not push the drug. Okay? So that is the important one. So whenever you inject a anesthesia, always confirm you are not in a vein, because lignocaine in a vein can be dangerous. Patients will die, and we have seen this many times. So this is the first part about local anesthesia. If you have completed writing, I can proceed.
Done, sir.
Yes. What is step number 4?
Incision.
Incision. Very good. Now that means in this topic, what I am going to tell the examiner is that the area is painted with povidone iodine. This is point number 1. Point number 2, the area is draped, is point number 2. So the area is painted with povidone iodine and it is draped. Just allow me a minute, please.
Recording stopped.
Okay, is the screen visible, sir? Hello?
Yes, sir.
Yes, sir.
Right. The area is painted with povidone iodine. The area is
Recording in
draped,
progress.
and the local anesthesia is infiltrated. How is it infiltrated? You are not required to know that. Okay? The technique is only one word. It is called as field block. It is called as a field block. The incision is made along the long axis of the lump. That means if this is the lump has a diameter of x, you are required to make an incision which will be x, half of x and half of x. Please remember that. If the x is say 10 centimeter, then you are required to make 5 and 5, a 5 centimeter on each side, and you are required to make an incision like this. If you have completed writing, then we'll proceed then.
Done, sir.
Done? Thank you. What is the next step? What is the next step?
Salient steps.
Salient steps. Mhm. The salient steps of this are: the skin flaps are raised. The point number B is the lump is dissected. The lump is dissected till the base oblique the pedicle. Number C, the hemostasis is attained. Number 4, lump is excised completely. If you have completed writing, please tell me.
Done, sir.
What is the next step? What is the next step?
Drain and
closer.
In the rinse and the closure section, if it is a large cavity, now we don't have a definition what is large and what is small. A corrugated rubber drain is placed. In the operative, in your instrument class, I will be showing you this one. In a small cavity, the walls are opposed by absorbable suture. Number B, skin is closed by interrupted nylon stitches. What is the next step?
Post-op direction.
Post-op directions are only 2. Analgesics are the only advice. If it is, you don't need a routine antibiotic, you can give mupirocin skin ointment. If you have completed writing, please tell me.
Done, sir.
Last one, advice on skin stitch removal. Date. Yes. Okay. Completed?
Yes, sir. Yes, sir.
What is the 8th one?
Post-op complications. Post-op complication.
Surgical site infection. Number 2, bleeding. which can usually occur within 24 hours of the operation. Usually. These are usually the complications, and this completes the first of your operative. Just tell me if you have completed writing.
Done, sir.
Done, sir.
Done. So this thing that you have written is about any lipoma, sebaceous cyst, say keratocanthomas, skin nodules, etc. So this is a very common one to be asked, and particularly if you have a short case with a lipoma and a sebaceous cyst, which they are, and everyone is asked this. Even if you have given this as a long case, you are asked this one. So I hope this is the reason I kept it as number one, because this becomes that important. So let us talk about the next one, that is something called a circumcision. So when you talk about the next operative on circumcision, or operative or operation 2 in the minor, is something called circumcision. Now circumcisions, by definition, you are asked by the examiner, what is circumcision? Circumcision is a surgical removal of foreskin, commonly called, you should be calling it as an excess of the preputial skin. The indications of a circumcision, please do not say religious indications. You are a doctor, you are not going to say religious indications. Indications are, number one, phimosis. We have had a case discussion on phimosis. Number two, complications of phimosis. And I hope you know what are the complications of phimosis. We will not go back to that, but only one thing to remember. Paraphimosis is a common complication. A balanoposthitis. Number three, a patient with a urinary tract infection, and rarely in an adult, suspected cancer of the prepuce. A BXO is an honors getting answer. Do not mention BXO unnecessarily. Now, what is the contraindication of a circumcision? One word answer, please. What is the contraindication, sir? Hello. Am I audible?
Yes, sir.
Why is it contraindicated in a hypospadias? Why is it contraindicated in a hypospadias? What is this kind of
For reconstruction, it would be needed.
Very good, very good. This is an honors getting answer. What is this prepuce called as? Hooded prepuce. And why do you require this? Because for reconstruction, for the new urethra, you require this part. Hence, it is contraindicated in a patient with hypospadias. So please remember that. So indications are these two. If you want to add a religion as an indicator, religious circumcisions, well, I will not be mentioning that in an exam. But if you want to mention that, that is point number 3. Now, what is the anesthesia that you require? 2 words only. Number 1, for children and uncooperative adults, always go for general anesthesia. For cooperative operative adults always go for ring block, local infiltration by lidocaine or lignocaine. With adrenaline or without adrenaline? With adrenaline, very good. It is without adrenaline. Can you tell me, sir, why it is without adrenaline? Very good. One line answer, because it contains an end artery. Very nice. And platinum getting question. What if the operator has accidentally injected with adrenaline? What is the treatment then? Number one, talk to your lawyer. That is the first treatment maybe. But anything more? If you have accidentally injected, have you heard the injection of this, which produces a vasodilatation? But this is an honors getting answer. Don't unnecessarily mention this. If you have accidentally given adrenaline, that is really bad. You shouldn't have done that. So this completes the first case of discussion. 1, 2 done. Now talk about the next one. The incision and the steps of the operation. We combine in this case 2. There are many ways of doing a circumcision. I will tell you what is the way that you are required to say in an examination.
স্যার প্রি-অপটা কি আগের অপারেশনের মতোই হবে?
Yes, sir. Nothing that special in a pre-op. Nothing that special in a pre-op. Okay. Right. Now, in this incision and the steps, the first step of this is after antiseptic dressing and draping. Antiseptic dressing and draping. Step 2 now is holding the preputial skin with 2 mosquito forceps and a release of adhesions of glands with prepuce. The step 3 and this will be a dorsal incision is placed, which ends at least 5 millimeter proximal to the sulcus of this. If you have completed writing, please tell me.
Done, sir.
The step 4 will be the incision is extended on the ventral side up to the frenum linguli. No, not frenum linguli, sorry. Up to the frenum okay. What is this? I will make you understand by a picture. The step 5 is the frenular artery is ligated. Okay. Step 6 interrupted sutures are placed between the cut margin of the skin and the preputial, the cut margin of the skin and the preputial cover or remnant. The step 7, hemostasis is attained. Step 8, urethral meatus is checked for stenosis and if stenotic, meatotomy is done. Please tell me when you have completed writing, then I will make some pictures to make you understand.
Done, sir.
Step 9, dressings are done. Okay. So please remember that. Step 10, again, soakage of dressing and color of glands is checked to avoid tight compression dressing. So this is all things that are important. Completed?
Done, sir.
Done? So I'll again go back to the 10 steps. The first of the steps are holding the preputial skin with mosquito forceps. Now, if you have not understood what does this dorsal incision means, the dorsal incision means that if this is the sulcus and this is the glans, then an incision is made on the dorsal surface. Always remember this. It is thus made till, as you can see, we have ended a distance from the sulcus. So you do not extend your incision up to this point. And ultimately what we have to do is that we have to rotate the incision on the two sides. So this is all things that are done. You are required to know up till this. Finally, good students before giving an honors are asked, how is the frenular artery ligated? Now, this is something called as, understand this picture. If this is the frenular artery, this is the frenular artery that has been cut. The red color is the frenular artery. The deep colored suture is the stitch line that we are using. Understand that it is given in this way. This is called as a frenular U stitch. So this is called as a frenular U stitch. You are not required to know the technical details. If you will be doing the operation, then you will get to know this. Once you have given this, you will get to know this. This is called as the frenular U stitch.
Sir, can you please show the diagram of step 3? থ্যাংক ইউ স্যার।
স্যার এখানে সালকাস নিয়ে কি বললেন?
You have to stop 5 millimeter before the sulcus or the corona blandis, whatever you call that to be. And see that I have drawn a green line. You are not going to go to that green line. Have you completed writing?
Yes, sir.
Yes, sir.
This is all that you need to know for the major steps. Now come to the post-op complications. Now the post-op advice that is asked is, the post-operative advice is only one: to change the dressing every 24 hours. Number 2, application of mupirocin ointment locally. And so this is what you are advised or you are required to say to the patient. You can give an analgesics. SOS, no oral antibiotics, please. Now, in a case of post-op complications, in a patient with a post-op complication, remember we have number 1, in the post-op complication story, the number 1 complication always is bleeding. This is the most common complication after any circumcision. Number 2 is infection, which is a less common event. And number 3, excess skin excision is going to produce a fibrosis or a fibrotic scar, which leads to a later contracture, which is a very bad thing to happen. But we have seen all things happening, so that is really bad. Hello?
Yes, sir.
But that's also. One day someone was talking about an operation called as Prippucioplasty. Now, Prippucioplasties are very advanced operations that are done only by pediatric surgeons for a special type of phimosis where there is minimal amount of scarring. That also there is an age group. It is usually not done beyond 2 to 3 years of age. You are not required to know an operation called Prippucioplasty at MBBS. Even my postgraduates are not asked this. Unnecessarily do not read about Prippucioplasty. So this is a very common operation called as circumcision. Any queries, please ask me now before we proceed to the next operation.
স্যার ফ্রেনুলার আর্টারি যখন রিপেয়ারটা করছি তখন ওই ইউসেপড লাইগেশনটা করে নাকি না ফিগার অফ 8 একবার বলেছিলেন মনে হচ্ছে?
Sir, you can, if you complete this U stage, sir, it will look like a figure of 8. I do not mention the figure of 8 now because it is usually the Bailey love stuff which people want to hear in an exam. In a real world, if you complete the 2 stitches, it is going to look like this kind of a stitch, which will resemble a figure of 8 technically. And hence we do not call this to be in this region because examiners do not want to hear the figure of 8 in this area. They want to hear you saying this word called as frenular U stitch. Okay, chalo. Thank you.
Okay. Can you please explain again the frenular U stitch?
Explain. Sir, if you are doing the operation, then please come to me. I will tell you what exactly. The explanation is that you are trying to have the artery in between a loop of suture. So this is a loop of suture. One end is this cut end of the artery and another is this cut end of the artery. That is called the frenular U stitch. That is all, sir. The rest of the things, if you want to have an hands-on, then you will get that idea. What is a frenular U stitch?
Thank you, sir.
Thank you.
Sir, distance from corona glandis to কত সেমি?
5 millimeters.
Thank you, sir.
Come to the next operation. Operation 3 in minor is
Sir, till what time will today's class go on?
around 1:15.
Okay, sir.
We will talk about an intercostal chest drain, an ICD. Now, ICD steps are also taught by medicine guys, I think. I do not know about what they are going to talk about, because I will not be confusing you, and we'll say that in ICD, particularly in patients with trauma or accidents, the indications of an operation or indications of an ICD placement are: number 1, pneumothorax; number 2, hemothorax; number 3, hemopneumothorax. These are all seen in patients with trauma. If you talk about non-trauma, then pleural effusion will be the only single criteria. Empyema thoracis will be another one. Now, I will be not teaching you these parts, because if I teach them, you will get more confused, and they are usually taught to you by chest medicine and general medicine, sometimes even maybe pediatrics, because these people will be giving a chest drain which will not match with the description that I will be giving you. So I will not confuse you. I am not saying who is right or who is not, but when we'll be talking about chest drains in surgery, we'll be talking about trauma. So let us stick to one point, because unnecessarily getting confused is not going to land you anywhere. When you talk about the next of the points, the next of the points to remember are: the indications are done. Now, when you talk about contraindications, technically enough, there are no contraindications, because particularly in a patient with a trauma, if you have suspected a pneumothorax, even remember, if you have suspected, forget about a proof, you will give a chest drain. Even if you suspect a pneumothorax, suspect a hemothorax, suspect a hemopneumothorax, you are allowed to give a drain, even if there is a minimal pneumo or a hemo. You do not need a chest X-ray to do that, or to confirm your diagnosis. Talk about the steps of the operation of ICD in trauma patients. Now, as I have said, medicine people will give a chest drain at a different site, and I'm not going to discuss about why will they give a chest drain in a different site. Now, when I talk about an ICD in a trauma patient, remember that this is a life-saving operation. So there should not be any confusion in any step of this. There would not be any doubts or any step in this. What is important is the step 1 is position of the patient, and the position of the patient is 45-degree reclined. The shoulder is, or the arm is, abducted externally rotated, which means the patient will be lying like this. So this is your patient. The patient's hand is like this. This is the clavicle, and this is the chest wall. This is the sternum. So this area is the chest wall. I will try to do a very schematic picture, and what I will try to also do is that this is the anterior fold of axilla, this is the posterior fold of axilla. So this area is the chest wall. Okay. So 45-degree, the patient is not sitting. Remember, the patient is not sitting. The patient is in a 45-degree reclined state. The shoulder and the arms are abducted. The patient's hand is externally rotated. Okay, so this is usually the position. The step 2 is to infiltrate local anesthesia in the triangle of safety. Okay. Now, what is this triangle of safety? So, the triangle of safety is bound by 3 lines. What are they? They are usually the lateral border of pectoralis major, upper border of 5th rib, and mid axillary line. If you have said the posterior axillary, if you have said the lateral border of latissimus dorsi, this is a wrong answer. So please tell me when you have completed writing.
Done, sir.
Done? Good. The step 3 is the skin incision is made. Length is 1 centimeter skin incision. Step 4, the subcutaneous tissues and the intercostal muscles are dissected till the parietal pleura is reached. Step 5, the pleura is punctured by a blunt hemostatic forceps and a finger is introduced along the tract up to the pleura. If you have completed writing, please tell me.
Done, sir.
Done, sir.
Done, sir.
This technically means that if this is the rib and this is the incision that you have made, these are the intercostal muscles. Always remember that, let me take a color please. This blue colored lining is that of the parietal pleura. This is the lungs. So the only thing that you have done in this picture is you have taken your finger and you have introduced it up till this line. If you are wondering why should I be doing this, this is because to push the lung or any other contents away from the wound site. I do not want that to get injured when I am going to introduce a pipe. So this is a step that many people don't do. If you have read a manual called ATLS manual, I hope you know what is the full form of ATLS. The latest edition. This is what is taught by ATLS. You can go to the YouTube to have videos. These are multiple videos in YouTube on ATLS. You can see that video. But this is an important step that many people may ask you. I do not know will ask, they may ask you. Okay? Medicine guys do not do this step, and that is wrong. Hence I told you I will not be teaching what medicine guys do. So this is what we do to give a safe chest training. If you have completed writing, please tell me.
Done, sir.
Let's talk about the next step. The step 6. The ICD tube is inserted and attached to the water seal drain bag. The signs of successful placement in the pleural cavity. What are the signs of successful placement in the pleural cavity? 1. Fogging of chest drain tube. Number 2. Movement of water column. Number 3. Bubbling of the water in bag on inspiration. This is a very important viva question. Number 4. Air entry in the pleural cavity on auscultation. And number 5, chest X-ray showing the correct location. This is an important question for both surgery and medicine. People will ask you, how do you know that the chest drain is in a proper place? 1, 2, 3, 4, 5. All of them are very important, and this is something that you are asked in an exam. Complete?
Yes, sir. Yes, sir.
Good. The step 7 is.
Can you please explain the fourth point?
Fourth